a Puscast covering the first 15 days of April in the year of perfect vision. References are available at edudoc.com, the home of my multimedia empire. Otherwise, not much to tell you in this COVID-ridden times, except there are still other infectious diseases to occasionally be concerned about, and we'll talk about them here. Let's move on then to the literature, shall we? I have always been a fan of the hygiene hypothesis, which basically says that it's important to wallow in filth as a child, as exposure to antigens and bacteria and the like lead to a, for lack of a better word, stronger immune system, or at least a more flexible immune system. And by not being exposed to said antigens, you are more likely to develop allergic and autoimmune diseases. Antibiotics could play a role in that antibiotics wipe out large numbers of organisms that you might otherwise be exposed to. And this study looked historically at the risk of childhood asthma versus how much antibiotics were prescribed as a child. And they found a, quote, consistent dose-dependent association between antibiotic prescription fills during infancy and subsequent development of childhood asthma. And it would appear that the type of antibiotic was not important. I was always pretty sanguine about my kids getting filthy. I still remember when Jeff turned over a rock and saw a slug, and before I could stop him, he popped it in his mouth. And I went, eh. In retrospect, however, considering the rat lungworm, maybe I shouldn't have been so sanguine. But outside of eating rat-derived parasites, wallowing in environmental filth as a child probably isn't all that bad for you. Delafloxacin, as long as we're on the topic of antibiotics, is a relatively new quinolone whose reason for being is that it's better against MRSA and otherwise quinolone-resistant organisms, or maybe not so much. I have found over the years that nothing gets resistant faster to quinolones than Staph aureus, and in this case they looked at the susceptibility of MRSA to delafloxacin in New York City and found that a whopping 22% of isolates were resistant. They were predominantly one strain, the ST105 strain, that was associated in New York with healthcare-associated infections. But it seems that nothing gets resistant to quinolones faster than Staph aureus, even with this agent, which allegedly was going to be superior because it needed multiple mutations to become resistant. Guess what? Been there, did that. Here is an interesting study historically and currently on herpes simplex. And here's the thing I didn't know. Quote, herpes simplex virus 1 and HSV2 diverged from one another approximately 6 million years ago, after which HSV1 evolved in the human lineage and HSV2 in the chimpanzee lineage. A human ancestor then acquired HSV2 as a zoonotic infection from a chimpanzee ancestor 1.4 to 3 million years ago. So HSV2 is actually an ape zoonosis that we acquired from apes. I'm not going to go there. And then has moved along in humans to cause genital herpes, mostly. The interesting thing from this study is that HSV1 and HSV2 are today recombining in human beings. I suppose that's either going to give us HSV 1.5 or HSV 3. And as a result, they can find at least 2 large recombination events in herpes in human beings. The significance and the worry is that if you give a patient a live vaccine for herpes, it could then recombine and come up with a new strain. Giving a bunch of HSV2 live vaccine to a place where there's a lot of HSV1, then you really could end up with HSV3. But to me, the more interesting thing about the study is that HSV2 is a zoonosis of about 1.5 million years duration. Also, where did chickenpox, i.e., varicella zoster (VZV), come from? It had thought that it had come out of Africa with our ancestors, but in analyzing the DNA of VZV virus around the world, there I was redundant, I should have just said VZV, it looks like Europe is the ancestral home of VZV and it spread across the world from there, forming, as is often the case, different clades throughout the world. When the rotavirus vaccine was first used, it apparently had an increased risk of intussusception, which I never understood from a pathological point of view. Subsequently, there have been studies to look to see if there is indeed an increased risk in intussusception, and the answer is sometimes yes, is sometimes no. This study out of South Africa showed that there was no increased risk of intussusception in children receiving the rotavirus vaccine. But this was not in agreement with every study, and results vary depending upon the population studied with the vaccine. So there used to be dengue in Guam. However, in the 40s, the U.S. military wiped out the vector, A. aegypti, and it is still gone. However, the dreaded Aedes albopictus, which is a good vector for dengue, is now present in Guam, and it would appear that it has transmitted, likely, a case of dengue, as there's a report of a resident of Guam with no travel history who developed dengue. A. albopictus is all throughout the southern United States and has been responsible for the widespread dissemination of diseases like dengue and chikungunya in other countries. So there's a case in Guam, but who knows? Someday there may be widespread disease in the southern half of the United States where that particular mosquito is widespread. And if you're going to Guam for summer vacation, take along your DEET. Measles is, of course, a miserable illness for children that get it. It causes significant morbidity and some mortality. The thing about measles, though, is it infects your white cells. You get a neutropenia when you get an acute case of measles. And, quote, it may infect 20 to 70% of B, T, and plasma memory cells during the acute illness. What is the effect of that? It wipes out your immunity towards pathogens that you've had prior exposure to, rendering you susceptible to infections again. So say you've been exposed to pneumococcus. You have anti-pneumococcus antibodies. Measles wipes that out, and you need to be re-exposed to get your immunity back. So not only does measles make you miserable and perhaps kill you from measles, but it also gets you at risk for reacquiring infections that you've had in the past. And to develop immunity to those organisms, you have to be re-exposed again. Quite the little bastard measles, huh? Wiping out all your immunologic memory, rendering you susceptible to infections all over again. 2 case reports, 1 case report actually of 2 patients who, being injection drug users, went on to develop brucella endocarditis, and neither of them were in rural areas nor had any discernible exposure to sources that would give them brucella, although one patient was, quote, unwilling to discuss the source of his opioids or injection equipment despite repeated requests. So who knows, maybe he was shooting up with goat milk. It looks like one case was in Ohio, the other in West Virginia. So I would not have suspected the brucella as a cause of culture-negative endocarditis in an injection drug user, and I'll have to file that away in the back of my brain. Good enough actually sometimes isn't good enough. This study looked at the mortality of staph bacteremia, and one of the things that was associated with decreasing mortality, which has been declining over time, has been getting the patient on an anti-staphylococcal antibiotic, specifically a beta-lactam. So continuing the patient on the ceftazidime because it's good enough, or vancomycin because it's good enough, isn't good enough. Keeping the patient on a non-beta-lactam drug when they have MSSA in their blood is another way you can increase the mortality of your patients. MSSA should be treated with one of two drugs, cefazolin, or as my pharmacists call it, cefazolin, or nafcillin/oxacillin. And that's it. Anything else, and your patient is more likely to die. And as is often the case with beer, ice cream, and joint aspiration, more is better. If you take 20 cc's out of the prosthetic joint instead of 10, you have a better yield for identifying the pathogen involved, as opposed to, say, 10 cc's. So more is better if you want to get the infecting organism, not only in blood cultures, but in aspirations of infected prosthetic joints. And ID is often all about the curious exposures that lead to infection. So they call it gas station X. The CDC never gives you the name of the involved establishment that led to an infection. So it's gas station X. They had nacho cheese sauce festering away like a staph boil. In this case, it's more like a Clostridium boil, because 10 patients who ate that nacho cheese came down with botulism. 7 of the 10 required ventilation, and 1 of the 10 died. I eat damn near anything, but I've always found that nacho cheese that they squirt all over the nachos, it does to me look like some sort of plastic or a bad staph abscess, so I'm never inclined to eat that stuff. But beware the nacho cheese sauce next time you go to a gas station. The big 4 meningococci, or A, B, C, then you skip all the way down to W135. Sub-Saharan Africa has X, and no, it's not from gas station X, it's just called X. There's now a serogroup E that's causing disease in Australia. So add another meninge to the alphabet soup. I don't know if you remember, going back a couple of years now, there was a big brouhaha over giving vitamin C, steroids, and thiamine to septic patients in a non-controlled study. It was touted as a game changer. Where have we heard that phrase before? What a surprise. There is a randomized controlled trial of hydrocortisone, vitamin C, and thiamine versus placebo, and it didn't do diddly squat. This happens over and over again in medicine. The Shakespearean equivalent of all sound and fury signifying nothing, a tale told by a non-randomized controlled trial, where some therapy is touted as a game changer, and in subsequent studies it's found to do nothing. At least hydrocortisone, thiamine, and vitamin C is unlikely to cause harm compared to our current equivalent, hydroxychloroquine, which you can predict on basic knowledge of the drug that it will do nothing against COVID but kill a couple patients. And that already seems to be panning out. In the case of hydroxychloroquine, it was all sound and fury, a tale told by an idiot president. But unfortunately, it's a tale that is told over and over again. The old saying is, those who do not remember the past are doomed to repeat it. Hell, even people who remember the past are doomed to repeat it. People don't learn from the past. But it's an interesting psychology how both patients and doctors would rather die of doing a worthless therapy or even a dangerous, unproven therapy than die from doing nothing at all. For Nocardia species, Bactrim tends to be the treatment of choice, but not everyone can tolerate Bactrim. There's a nice series of patients who were treated with linezolid, and the organism is virtually always susceptible to that antibiotic, and the patients did quite well with it. So if you can get them past the peripheral neuropathies, linezolid would be a good choice in the treatment of nocardia in patients who are intolerant to TMP sulfa. And that's really it. Less than 15 minutes. I think that's the shortest Puscast in history. But sometimes there just isn't that much to talk about. So that ends the Puscast covering the first 2 weeks of April in the year 2020. References are available at edgydoc.com, home of my multimedia empire. Otherwise, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you in dictation, and take it away, Jeff.